Recording now. So from now on we're being recorded, so no libelous comments on anybody. And I'll bring my PowerPoint back up. So this is the second shot at ehealth, and so what I was going to ask you to do first of all was in the chat room, let's see what you can remember about what I thought were the 7 trends in information technologies that are changing health and social care, and which of those do you think are the most important for your area of work. So I'm going to put the chat room back up again now and let you talk about that. So what do you remember what I had down as the 7 trends in information technologies? That's a bit of a test, isn't it? A bit nasty. Or if you can't remember, just make them up. Anybody there? Yeah, okay. Both got that one. Yeah. Bonnie and I were just talking about her poster that she's going to be doing, which will be about telehealth on COPD. So, what else? Wearable tech. Yeah, that was another one. Yes. And Bonnie, you weren't there yesterday, but in the session yesterday we had one group that was trying to develop, had the idea of some sort of wearable patch that would send off signals about blood pressure, blood sugars, and various other sort of vital signs to a mobile phone, and so to a carer, so that they would know how well that person's doing. So that's, which is like the extension of the telehealth idea. We've got 3. Anything else? That's a good idea. Yeah. There's been various European projects looking at this sort of wearable technology, and as you know, probably it's coming into consumer health quite a lot from many amongst athletes who go around with various bands, service user involvement. Yeah, sort of. I think it's just the shift in power. Okay, I'll carry on. The things that I had down were these before. So the electronic records decision support. Let me just move that. Mobile, just basically, to some degree, it's implied in by you saying wearable technology, but mobile, everything's going mobile. The service user involvement, yes, really patient-led ideas and social media. The use of patient feedback sites and so on is growing rapidly, and services are having to respond to them. There's the sensors, telehealth, telecare, so that's the wearable tech and the telehealth. Big data is another one, that where because of this wearable technology, and because we're getting masses and masses of data, we have to have ways of dealing with it. And what's happening is that because you've got such masses of data, you can start to spot trends and spot things that are happening that you weren't able to do beforehand. But from a computing sort of point of view, you need to have new techniques for dealing with that big data. And then the last one was robotics. Robotics will come in, and we can think about how different types of robots might be used either in the home or in hospital or elsewhere. So in this session, I want to talk about patient access to records and patient-held records a bit more. I want to talk about the ideas of ehealth readiness and superfast Cornwall. So Bonnie tells me that she lives in Liskeard, so I don't know if you got superfast or not, but we're going to talk about that. And lastly, talk about health promotion using online websites, apps, and devices. So first of all, patient access. It's when as you can tell, I'm pretty ancient, and in the late 1970s when I started working, this was sort of the sort of records that we were dealing with. Unfortunately, some of them are still around, but you won't be able to quite see that one. On the front of it, it says not to be handled by the patient. And that was certainly the attitude about patients having access to their information in the 1970s. So we've moved from these chaotic records, very little information, paternalistic attitudes. And when I was starting work in late 70s, early 80s, I developed a clinical information system. We produced computer-produced patient-held records, and others were doing sort of similar things. So during the sort of the late 70s, early 80s, we see projects that you were using this sort of paper technologies, but computer-produced, and starting to involve the patients. At that time, during the 80s, we were still seeing debates in the BMJ, somebody arguing against showing their records, somebody asking the benefits of perhaps patients seeing their records. So it was still fairly hotly debated during the 80s. But times have moved on, and attitudes have gradually been changing. And certainly during the 1990s, we moved from a state of having very little information for patients to the web starting to become widespread, and patients starting to access information. So we went from a problem of having no information to having perhaps too much, and being able to find the needle in the haystack. So one of the benefits of giving patients access to their records was that we might be able to use their own medical record to help them find the needle in the haystack, help them find the right bit of information for them. So in the late 90s, I developed a system this was in Glasgow, where we gave patients access to their own medical record about cancer, and it started off with their own record. So you see here it says your prostate cancer is described in so on, and people were able to touch on those words and get explanations as to what prostate cancer meant, what grade 2+3 meant, what stage meant, what TNM meant, and so on. So it used the medical record to index the sort of information that was starting to become available on the web, and that was found to be more popular with patients than just giving them general information. So by personalizing it, tailoring it to their own needs, that was effective. So I think now in 2014, the argument's largely won about whether or not patients in principle should have access to their records and what the benefits of it are. I don't know why my bloody thing my computer keeps sending me warning messages about colour schemes. Don't want to click yes, but it's going to keep coming up. Sorry about that. So we've now got a stage where we've got routine access to their records for some people, some innovation leaders. I'll give you an example in a minute. And we don't have that many people, many clinicians publicly at least, arguing against the idea of patient-held records. And we've actually got government policy that everybody should have access to their record by next year. I can't actually see it happening, to be honest, but that is actually government policy now. Let's just see what Bonnie's saying. Yeah. Yeah, I totally agree, Bonnie. But the case is that actually few GPs or hospitals yet offer this access routinely. Actually, at Derriford, for example, you'll know that people in the renal clinic have access to their records through something called Renal Patient View. And what's Rachel saying? Yes, more of a partnership. I think that's right. I mean, people, if you have access, and you don't have to keep asking I mean, I don't know about you, but I go to the GP, I forget the last time I was there. I forget what I may have prescribed, or you don't know what your past vaccinations are. And if I just had access to that, it would help my understanding and my memory. There are people who are doing this fairly routinely now. You'll all know this picture of this horrible man, Harold Shipman. Interestingly, he was at a practice in up in the northwest called the Horton Thornley Medical Centre, and all his patients were taken over by a man called Amir Hanan. And one of the things that he said right from the start was, we've got to have absolute transparency in this practice. There's no more hiding of what's going on. So one of the things that he really pushed has been patient access. And you see here, this is a bit of an excerpt from his, or a clip from that website, htmc.co.uk. You can have a look at it afterwards. And they've got 2,000 patients who've got access to their GP records with understanding, as he says. So he's really gone making a strong effort to make sure that patients understand their records, understand how they can use their records. And Amir Hanan has got lots of other innovations in the way that they deliver their practice. And there are various other condition-specific conditions where people have got access. So in Scotland, there's a thing called My Diabetes, My Way. As I just said, for renal conditions, there's renal patient view, and most GP systems actually have a patient access option. So any GP practice which has EMIS can, if they want to, turn on the patient access option. So we're really waiting for GPs to get behind this. And in hospitals, it's perhaps a little bit more difficult because the hospital records aren't so good, except in these cases of things like diabetes and perhaps renal conditions. So so in the chat room, then you're already chatting away anyway. Just wondered if, as a patient, have you ever seen or read your own medical record? As a professional, well, you're already giving your opinion, but maybe just answer it again. How do you feel about patients having or even holding their own records? Yeah. Have either of you ever had access to your own record? No. Yes, I mean, despite all this, I haven't actually had access to my own record either. I did ask my GP to have a look at my own record, and I was allowed to see the paper version plus some printouts from the computer, with a receptionist standing behind me, making sure I didn't do anything with them. It was most pretty uncomfortable. Rachel's in my uncomfortable position. Yes, it was an uncomfortable position for me reading my record. So you weren't keen on that, Rachel, then? Oh, I see. Yes, I mean that's a very good point, Bonnie. That I mean one of the arguments in favour of giving patients access to their records is that, I mean, certainly in the 70s and 80s, I don't know, hopefully it's not the same now, but there were a lot of sort of gratuitous, or at least value judgments written into the way medical records, I'm not sure about so much nursing records, but certainly medical records were written. Things like, guardian reading mum, various comments about patients that you think, well, that's actually not relevant to what you're supposed to be recording there. And there are also many instances where, for example, with mental illness, already where maybe a GP or somebody has suspected that somebody was depressed or something, and it seems to me that they should discuss that with the patient, not just sort of record it. Yeah. Good grief. That's terrible. I mean, one of the issues, of course, is about third parties. So you do have this problem that if you're a suspected battered girlfriend, or if very stressed due to husband wife's illness or that sort of thing, where there's a comment that really involves a third party, there may be problems. But I think it just makes the practitioner think a bit more carefully about what should be written and how it should be written, and whether who might have access to it. Yeah. So I think we're pretty much agreed that we should be trying to do something about this and get patients access and get people to be recording the notes properly. In the end, this comes back to Bridie's problem in a way. It's about implementation, and it's implementing this and bringing the rest of the curve up to the leaders, people like Amir Hanan and so on. Okay, let's move on now and talk about Cornwall. Where do you live, Rachel? Are you a Devon or a Cornwall person, or a Somerset person? All right, you're a Devon, but you'll both have heard of the idea of Superfast Cornwall. So we have a project running in Cornwall to evaluate Superfast Cornwall, and I just want to talk a minute about this idea of e-health readiness, and what might make up the use of e-health. So this partly relates to, in a way, this partly relates to implementation and to Bridie's presentation. So I've done some work a few years ago looking at this. I don't know how this thing keeps coming up. Looking at the uptake of one particular website called Living Life to the Full and online CBT for depression. And this map here shows you where there was a high rate of usage of it compared to other areas. And this is a system which was developed in Scotland, and it was fairly highly used in Scotland. Interestingly, it was quite well used in Cornwall and in East Anglia, but other areas there was really quite low usage of this website. Now this was a website which is available to the world. It was free, anybody could use it. So this was an example of what you might call supply side e-health inequality, because the GPs or the outpatient staff or the community psychiatrists and the IAPT practitioners weren't recommending use of this particular website, and we think actually not any website. So we did a trial to look at raising awareness of it through Google Ads, but the point here is that there can be inequalities in the use of e-health. So when you consider something like Superfast Cornwall, and you might ask, well, is the implementation of superfast broadband across Cornwall actually going to mean that the young and connected will start doing ever more things on the internet, leaving the old and disconnected even further behind? So I have a PhD student who's trying to assess the impact of Superfast Cornwall. So in the chat room now, maybe you can just sort of say a word to what do you think, what does e-health inequalities mean to you? And do you think this is something worth bothering about? I mean, can it be measured? How should we measure it? How do we know if we're improving? Because people often talk about digital divide. You'll have heard that phrase a lot. Can we do something about the digital divide as applied to health? So in the chat room, what do you think about these three things? Just going to look at my email while you're doing that. Just check to see if Beth's managed to get in or not. No, it doesn't look like it. Yeah, I mean, I think as a definition, Rachel, that's sort of more or less about it. Yeah, if you've got ehealth stuff, does it reach everyone? Does it reach all the parts that other stuff reaches? And I think that it can be more than just information. So, I mean, the ehealth inequalities really, I think, comes down to, have they got actually physical access to the internet? Can they personally know how to use it? Are they ignorant into how to access the information and what to do with it? Do they have the skills? Do they have the social support to get there? Can they afford to do that? And then is it actually supplied to them? So going back to the living life to the full example, you shouldn't see those regional variations unless there was an equal awareness of those systems across the country. Yeah, and I think that you're right, Bonnie, that what we need to do is get professionals to be directing patients to services, and that's where I think professionals can help patients by just giving them a web address and saying, go and look at that one, so that people go to maybe the NICE or Department of Health or NHS or a recognised charity site rather than some quack. Yes, but I think you're right, Rachel. Everyone can go to a library, but a lot of people will be put off. They say, well, it's not for me, I'm too old, I can't manage to do it. And so quite often what you need is support to help people get online. Not everyone's got the family member who knows how to deal with it. Yeah. So is this something we should be worth bothering about? Because one of the things that people say is that the main digital divide is between the old and the young. So the rate of uptake of the internet really drops off quite dramatically for the over 60s, the over 70s, the over 80s. And one argument is, well, this lot will die off anyway soon. So what do you think? Should we be doing something about that? Yes, I mean, I agree with you. Is that clearly some people will say, oh, it's not for me, and doesn't matter how much you try and support them to make use of these technologies, they will say, well, I just really don't want to know, go away please. But I think there are many people who will say, oh, it's not for me, but actually if you can give them support in a sort of a friendly and supportive way, then they will use it. And that's where the Plymouth Senior Net idea came in, that you take somebody who's maybe 50 plus to help people who are 65 plus get online. It's also the idea I have with Skype on Wheels, which I've been doing with in care homes, so that they don't even need to know particularly they're using the computer. But there are things I think that we can do. The other side of it, of course, is that if you want to run something like a telehealth service or some other form of internet-based service, if you haven't got everybody online, if you haven't got everybody able to access these services, you'll need to carry on running it both online and face-to-face, which might be more difficult. Okay. Does your nan live in anywhere near Plymouth, Rachel? Hang on, you see what that says? No, Cheshire. Oh, okay, too far away. You might look online and see if there's some local scheme, because there are a number of schemes at the moment to help people get online. And the lottery's just about to put a whole load more money into getting people online. Some of their funding is mainly aimed at people of working age, but I mean, I think that you should buy her a tablet. My mum's 88, and she uses a tablet now, and she's you go and have a conversation with her, and she's always picking the tablet up and googling things to see if she can find something about it. We've even got her on Twitter, although she doesn't tweet, she just reads. So certainly the Plymouth Senior Net found that the tablets work very well, that they're very intuitive and easy to use, and there are various schemes. There are various schemes to help people online. I don't know if that's my end, Bonnie, or your end, but I will try and speak slowly, clearly, and repeat myself occasionally so that you keep up with what's going on. Okay, I'm back. Good. So that's really it on the patient. The idea of eHealth readiness. One of the things that I've done locally is to try and develop a questionnaire and a measure of eHealth readiness and eHealth inequalities, because one of the problems is that if we want to have some intervention, such as volunteers helping Rachel's granny online, or helping people with COPD in Cornwall to use equipment and use the internet, we need to have some way of measuring the before and after of that intervention to know whether it's worthwhile. And my take on this is that interventions are good if they improve eHealth readiness and at the very least don't increase eHealth inequality, preferably they decrease it. So there's a problem with Superfast Cornwall, for example, is that they might well improve people's ability to use the internet for health, but they might well make it a lot easier for the young to do even more, and the old to be left further behind. So I think with any intervention needs to keep inequality in mind alongside effectiveness, because you can, if you think about a graph, let me go back to, have I got a graph here? No, I haven't. If you think about like a normal distribution where we move if you have a graph, you can move the mean up with it, but have a wider spread at the end of it. So you can have an increased mean, but an increased standard deviation. So the standard deviation, in a way, is the measure of inequality of eHealth readiness. So I've talked about this bit before, and quite a lot. From the Senior Net, volunteers helping people get online, and as you see there, James is using a tablet with this gentleman who was 92, I think. And so in terms of measuring it, we need to move from a binary, got it, not got it, through to maybe some sort of measure of distribution like that. Just as we do with looking at household income distribution, we don't say people have got income or not income. You say, well, what's the spread? How do we compare the top 1% with the rest? And are we an equal society or a more unequal society? That's it really on that topic. And then the last topic I wanted to deal with really was health promotion and the internet. And so you might like to have a look at some of these various health promotion websites. So Down Your Drinks, one that you could Google afterwards. There are various websites that help you try and improve your lifestyle with alcohol, smoking, weight, exercise, sexual health, whatever. And there are lots of them. and there is some evidence that that people taking part in trials that using such websites have an improved understanding of the health determinants of health, such as diet, alcohol, smoking. And there's also some evidence from some of these studies, at least in the short term, that people have improved health behaviours in diet, tobacco, alcohol abuse, sexual behaviour. But one of the problems, of course, with most of this stuff with health promotion is that these studies tend to be on a fairly short time scale, and therefore to be able to show improved health outcomes is quite difficult. And there's less evidence on the maintenance of changes in lifestyle. I'm going to, I don't know what I'm going to do, is turn that video off. Hang on. That might speed it up, stop any noise. Sorry, just adjusting the webinar. But if you've got evidence from the shorter term studies that you can actually improve health behaviours, then you can use epidemiological evidence to model what might happen in the longer term if that change in behaviour is maintained. You'll be aware of the different types of evidence, and you'll be aware of that meta-analysis will be like the top form of evidence, really. So in this particular study, Portnoy 6 years ago looked at 75 randomized controlled trials and found these improved knowledge, attitudes and intentions between those in the case group and the controls for these types of intervention. And in these various studies, Portnoy found improved diet, less tobacco use, less substance misuse, improved sexual health, and so on. But concluded that further study was really needed for the longer term effects. To give you an example of one particular study from that meta-analysis, this was a New Zealand study by somebody called Kipri and others. There they took 2,500 students and who were drinking within the harmful range. They were randomized to have the intervention or not. 84% completed at least one follow-up intervention. The intervention itself was a 10-minute web-based motivational assessment and personalized feedback. So it wasn't a big intervention, just 10 minutes really online. And yet they found that the intervention group at 1 month drank less, smaller quantities and less alcohol overall. And at 6 months there still seemed to be, so a 10-minute intervention online seemed to work even 6 months later. So it was quite successful really. But of course that's maybe not always the case. So in the chat room, what do you think about these types of internet-based lifestyle changes programs? Do you think they can be useful? What do you think are the main problems? Yeah. Yeah, I mean that's I think one of the major drawbacks of these, Rachel, is that you've got to be motivated in the first place to actually take part. So in any randomized controlled trial of, say, something like down your drink, you've got to be you've got to actually take part in the intervention. So and quite often it's the people who smoke and drink and don't exercise and are obese and so on, who you wouldn't get them to actually take part. So you've actually already got people who are online and willing to take part in an intervention. Yeah. Yes. So, but that's right as well. That you for some people it will work, and because one of the advantages, of course, of online interventions of this sort is that basically their marginal cost of providing them is virtually zero. So once you've developed a website, for example, to help people reduce their alcohol intake or increase their exercise, it doesn't really matter whether you've got 4 people doing it or 4 million. Yeah. One of the things that you find with all these online interventions is that the attrition rate is normally very high. Is that the down your drink, I think, in the end they had something like less than 10%, I think, got through to the end of it. But as you say, Rachel, to some degree there's nothing to lose because there's no real marginal cost to getting more people to do it. And I think you're right, Bonnie, that one of the things to do here is to make use of the social aspect. So you mentioned Facebook, and now you're mentioning schools and colleges, and I think that's right. Is that a lot of the interventions work particularly well where you can manage to get a bit of peer pressure working. So the buddy schemes. So any health promotion online where maybe there's some sort of form of competition, or you've got a friend who notes that you haven't recorded your weight on your Facebook page or whatever it is. I know I've noticed in Twitter actually over the last few months or so, a number of people have been posting their they've been wearing some sort of one of these wearable bands, and it's been recording how much exercise they're doing, and they're I'm not sure what else, and they've been posting their results on Twitter, and then other people who are taking part of this stream have been giving them the well done and the not well done. So a bit like an online Weight Watchers idea, but where you go online and get the peer support while also getting the good information from particular sites. But the main problems are often the evaluation. How do you evaluate something? I mean, so if you want to do, for example, a randomized controlled trial, and you've got the problem that you've already stated there, Rachel, that the people are already on the first point or 2 points up on the stages of change model. That is, they're already always willing to think about making this change, and therefore they're willing to take part in this trial. And then you've got huge dropout rates, so they're quite difficult to do these studies and to actually prove to somebody that they're worthwhile. One of the other ways of getting longer term support is, of course, to start building in things like text messaging from the website. So websites, you sign up to the website, and then it also sends you messages at certain times of day. Or if you've got a smartphone, you could easily imagine in the future that as you pass Greg's the baker, it sends you, because it knows that your phone knows your position in relation to Greg's the baker, and it can send you a text message and say, don't go in there for that donut. It's not going to do you any good. Just remember what you said. So these sort of feedback and goal-driven systems have been tried. They've been tried in outpatients as well. There's with like hospital populations. So it was used with a group of people who'd been, I'm not sure if they were in A&E or where they were. They were turning up to hospital having self-harmed, and then they engaged in a contract where they gave the computer system messages that the computer would then feed back to them when they felt they needed that support. No, are they? Right, okay. That was interesting. What program was that, Rachel? Any idea? Okay, well, I might try and see if it's on catch-up. I might get it later. So I've got a very short session today, really. That's really got down to the end. I think rather than sort of listen to me babbling on, you might just like to read around some of those different things a little bit. And I'm not even giving you a reading list. I think all you need to do is just go into Google and find a few things around. First of all, computer patient interviewing, which is the thing that we talked about in the first webinar. Read a bit about patient access to records and tailored information. Read a bit about using the internet and other opportunities for health promotion, and think about, given the benefits that some of these studies have shown in particular recruited patient groups, you might think about what sort of study or evidence or action do you think we might need to implement some of these to have better healthcare in the future? So do we need more randomized controlled trials or systematic reviews, or do we need some other form of study? And I have to tell you, I don't know what the answer to this is, so I'm just interested to know what your views are. How would you, as professionals, be convinced about what to go forward with? What sort of evidence do you think we need to implement these types of changes that we've been talking about on the first webinar and this one today about computer patient interviewing, patient access to records, health promotion, and so on? What would you do as a professional? What would make you change your behaviour? So that's your thing to think about. And shall I turn your sound back on? See if you've got anything to say. Hang on a second. Okay, you're both back online to talking.
I mean, I think once you put something like this out publicly, and there's government funding for, you know, to educate people and involve others, then it will catch on, won't it? But at the minute, there's probably fewer people than we think that actually have an interest in this sort of thing. You know, like I say, starting in schools and colleges, and sending out little groups of people to start health promotion. I mean, we all learned about health promotion years ago, but, you know, from an ED point of view, what's the most appropriate time to tell somebody to stop smoking? It's certainly not whilst they're having their MI. I might tell them 20 minutes later, but who knows?
Do you think there's any prospect of building in health promotion into the emergency department? I mean, because you obviously you're always concentrating on the problem they're presenting with at that time.
Oh, definitely, and we do it every day. As I say, we wouldn't tell somebody whilst they're having their ECG and they're going to cath lab, but, you know, I always still say to them, you know, the fact that you're smoking and you could do with losing 3 stone it is relevant, and you need to think long and hard about your lifestyle changes now. Oh God, yeah, we still do it all the time. You know, from anybody that comes through the door with a minor injury or minor illness, to patients that are going to consequently die if they don't alter their lifestyle change and behaviour as a consequence of their comorbidities.
And do you think there's opportunity for you know, using the internet or mobile phones or something else in as a sort of a follow-up for when they leave? Because you basically don't see them, well, you hope you don't see them again.
Yeah, I do. I mean, we're doing patient satisfaction surveys now, which is a national thing, a friends and family test, which has to be done. We're audited and monitored on that on a monthly basis. Well, once the government actually set it as a target, you know, it ups the ante, doesn't it? It's like anything else. Stroke wasn't interesting years ago until they formed a stroke pathway, and you know, patients have a better stroke care now because they go to a designated unit for rehabilitation. So, you know, if the government threw enough money at it and set it as a target, and, you know, I'm not big on policy, and I do think it takes you away from your nursing tasks, but in the bigger picture, you know, in 30 years' time, we'll see huge improvements in you know, in health, won't we?
Rachel, any thoughts about
we have to give a lot of health promotion advice antenatally to all pregnant women, but the onus is very much on the community midwife to give that. It's a huge part of their job, and it'd be good if we could back that up with something else as well, rather than just expect a midwife to deliver that information at the beginning of the pregnancy, and then, you know, they follow it up. They have to follow it up with questions throughout pregnancy, but it's quite a yeah, in-your-face way of doing it, is to have to keep on asking them face-to-face, you know.
But, you know, things change all the time. I've got a friend in Birmingham that's got a 4-month-old baby, and when I tried to speak to her yesterday, she was on her way to a seminar about weaning her child. Well, we went to a class and we had a little chat when, you know, I've got grown-up children, but things change, don't they? She's got access to online services on how to guide her to look after this baby. Yeah. And it's amazing, because for her, she's got an iPhone and she's computer literate. And and she's just finding the wealth of support and information amazing. Whereas I didn't get out. If you couldn't get out 20 years ago for whatever reason, then you were stuck in the home, and I don't know. It was harder.
No, I think there's a lot more information out there for people having babies, definitely, and also most places now. In fact, all the places I can think of, the maternity patients, they carry their own notes. They are paper notes, but they carry their own notes the whole time. And the only extra notes you'd have in hospital on hospital notes is because we have to have somewhere to put safeguarding stuff that's not in there.
But I bet it makes midwives and practitioners more aware of what they're writing in the Green Book.
Absolutely.
I mean, the sharing of information with regards to child safety and child protection, obviously, you know, it needs to be addressed as a separate issue. But you know, you make a judgment when you're making antenatal appointments with people, and you get a feel for that patient and how you build up that therapeutic relationship. And what you document is absolutely vital to that child's, you know, progression and a start in life, isn't it?
But also, it's always been very much that what you write down is very much there for the woman as well. And so that kind of hidden notes bit doesn't really happen, because in the same way, apart from possibly small episodes of their treatment that happen only in hospital, but so mostly they've got that information on them. And so obviously I would never write anything in their notes that wasn't okay with them.
No, not at all.
What about any initial thoughts on this, sort of like my last bullet point there, on what sort of study or evidence or action do you think that we need, professionals need, to implement more things like computer patient interviewing? I mean, what, for example, Bonnie, in accident emergency, I mean, what evidence do you think Derriford might need for the ED to use that as some towards helping towards the triage and the data collection?
I can hear you. I'm just thinking, just there with me.
Okay, the sound went. What sort of evidence do you think that we need to implement things like computer patient interviewing, patient access to records, or using the internet for health promotion within practice? So, for example, within the ED, do you think we might look at the possibility of computer patient interviewing?
Yes, I mean, as part of the patient satisfaction survey, we could actually introduce another question to say, would you be available for consultation based on your experience in the ED? And you can actually tailor that to group-specific patients, can't you? You know, at the moment, we ask them whether they're satisfied, whether the department looked clean, whether they were spoken to with courtesy, and that sort of thing. But actually, we could tailor it to ask questions. You know, was your attendance today due to a link with your diabetes, or have you had an injury? And there are lots of people. We are in discussion at the minute whether it's appropriate to text people to ask for their feedback.
I was thinking
at the minute.
I was thinking more of the like history taking of computer patient interviewing. I mean, that's one. What you're describing is like the feedback at the end about the service.
Oh, right, sorry.
I was thinking more in terms of the, why are you here today? What have you got? Pain? Are you bleeding? Or have you got something? What are the different characteristics? And using these branching interviews, which would help to collect part of the presenting signs and presenting symptoms for you to then use, like the computer might then produce a summary for you to look at. I mean, what sort of evidence do you think that the ED would need to decide to go and implement such a system?
I think the difficulty that we have at the minute is that, you know, everything goes through governance, and there's nobody that specifically deals with this sort of thing, and the hoops that you jump through to do the simplest bit of implementation of anything, you know, which is linked really good with the work that Bridie's been doing over the last couple of weeks, but it's getting people on board. I mean, for example, I've started this advanced nurse practitioner service, and and actually there's lots of interested people because it's a very good idea, you know, and nationally it works. But there's actually nobody that's got the time to deal specifically with it because everybody's remit is so huge. But it'd work if you gave linked people tasks and projects to do, definitely.
So, sorry, Rachel. Yeah.
When you say about the computer patient interviewing, I vaguely remember it. I think basically I can see also if you mention that to the manager therapist, and so they immediately, for me, it makes me think of the booking interview with an antenatal woman, and especially somebody who it's not their first time. There's an awful lot of that booking form that they could fill in themselves, which would save time and therefore money, and would be more efficient as a process. But I am sure that the midwives, the community midwives who would normally do that process, would say that they would miss that first interaction. It's not just about filling a piece of paper in, it's about meeting somebody, and as Bonnie said, it's about, you know, making a relationship with that person and finding out stuff about them that perhaps doesn't show up on the form. So if they're a bit nervous, or if they're, you know, their general demeanour is something that wouldn't come across necessarily, but perhaps there's still parts of that antenatal booking form that they could fill in before they had a meeting with you, which would cut down the, you know, 40 minute to an hour appointment down to a kind of 20-minute appointment.
Yeah. I mean, I think that's the way that they're generally used. I mean, that's the way that this is used in general practice, is that it allows the clinician, whether it's a doctor or a nurse or whoever, to use the summary to get straight to the real point of why that person's there. So, as you say, with your case, a lot of the routine stuff can be collected up front, which actually allows the midwife more time to get to know the person and to check out on things which may be missed by that standard interview.
Yeah.
So I mean, what in that case? I mean, you know, what sort of study or evidence or action do you think, if we were to take that forward, is it the same sort of problems that Bonnie's just referring to? Is it all about implementation and time and getting the responsibility and governance? Is that where the problem lies?
Well, it'll definitely be part of it, but also, I suppose, before you did something like that, someone would want you to do some kind of pilot to see what kind of proportion of the population were likely to engage in a service like that. You know, we're back to who's got the IT, who's got, if you have a form, maybe like a questionnaire that you're going to send out to women, which asks them as many questions as you can, and they fill that in and send it back to you, and then you have this 20-minute appointment with them. How many people are going to engage with that, and how many people actually haven't got a computer or wouldn't want to do it that way, or perhaps wouldn't have the intelligence or the ability to do so.
Okay, I mean, there are of course published papers with those sort of data in from different places for different systems. Okay. But I mean, I think what you're referring to is what Bridie sort of refers to as a context. So you need to know, okay, fine, it's worked in California, but will it work in Plymouth? So
there's a lot of very poor areas in Plymouth which possibly, you would have specific problems to this area. The person I'd sell it to would definitely be the head of midwifery and the people who manage the money, because I'm sure that they would see benefits in it to their service. It could be more efficient, couldn't it?
I mean, definitely, if you can cut down your consultation time from 40 minutes to 20, you're halving the workload of your nurses, of your midwives, aren't you?
Yeah.
In the bigger picture, you're talking years and years and years in advance. But I suppose it's got to remain an option. I think that the first question would be an option to the mother of which interaction would you prefer? Do you want a meeting, or would you rather complete the form? And because for some, they want to be in and out in 15 minutes. They've got other children. They don't want that conversation. And for new moms, and certainly young moms, they may want to come and they'll have lots of questions to ask you, as many questions as you've got to ask them.
you're back to also how many, how much would it benefit? So they'd want a kind of number, wouldn't they? Because like you say, some people would go for it, some people wouldn't. So it's always going to be an option. It's not going to be a this is how you have to do it. And then if you then take out, as you say, like the young people, maybe the vulnerable women, people who haven't got the IT set up, it may be that you're left with quite a small percentage of people who are going to fill this form in and go for that option. But I guess you have to start somewhere.
Yeah, definitely. And I mean, to do, I don't know, a 3-month pilot with specific midwives set to task to sort of run with this to see whether it works. Because we don't know until we try these things, do we?
No.
Okay, great. Anything else you want to talk about? If not, I think we'll finish, shall we, for today?
Yeah, that's fine.
Yeah. Okay, that's great.
Yeah, that's fine.
Okay, I'll stop the recording there, and I'll post it up on the portal later in case you want to look back at it and for the others. And for the rest of the webinars, all my colleagues, Catherine and Bridie and Ruth and so on, will be hopefully doing it on their own next time around. Now they've all done it once, so I'll see you again on the last day. And you always email me if you've got anything you want to ask about the module. Okay, bye.
Thanks a lot. Bye.
Bye. Services are having to respond to them. There's the sensors, telehealth, telecare, so that's the wearable tech and the telehealth. Big data is another one. That where because of this wearable technology and because we're getting masses and masses of data, we have to have ways of dealing with it. And what's happening is that because you've got such masses of data, you can start to spot trends and spot things that are happening that you weren't able to do beforehand. But from a computing sort of point of view, you need to have new techniques for dealing with that big data. And then the last one was robotics. Robotics will come in, and we can think about how different types of robots might be used either in the home or in hospital or elsewhere. So in this session, I want to talk about patient access to records and patient-held records a bit more. I want to talk about the ideas of ehealth readiness and superfast Cornwall. So Bonnie tells me that she lives in Liskeard, so I don't know if you've got superfast or not, but we're going to talk about that. And lastly, talk about health promotion using online websites, apps and devices. So first of all, patient access. Recording now. So from now on we're being recorded, so no libelous comments on anybody. And I'll bring my PowerPoint back up. So this is the second shot at eHealth. And so what I was going to ask you to do first of all was in the chat room, let's see what you can remember about what I thought were the 7 trends in information technologies that are changing health and social care, and which of those do you think are the most important for your area of work? So I'm going to put the chat room back up again now and let you talk about that. So, what do you remember? What I had down as the 7 trends in information technologies? That's a bit of a test, isn't it? A bit nasty. Or if you can't remember, just make them up. It's when as you can tell, I'm pretty ancient, and in the late 1970s when I started working, this was sort of the sort of records that we were dealing with. Unfortunately, some of them are still around, but you won't be able to quite see that one. On the front of it, it says not to be handled by the patient. And that was certainly the attitude about patients having access to their information in the 1970s. So we've moved from these chaotic records, very little information, paternalistic attitudes, and when I was starting work in late 70s, early 80s, I developed a clinical information system. We produced computer-produced patient-held records, and others were doing sort of similar things. So during the sort of the late 70s, early 80s, we see projects that that you were using this sort of paper technologies, but computer produced, and starting to involve the patients. At that time, during the 80s, we were still seeing debates in the BMJ, somebody arguing against showing their records, somebody asking the benefits of perhaps patients seeing their records. So it was still fairly hotly debated during the 80s. But times have moved on and attitudes have gradually been changing. And certainly during the 19... Anybody there? Yeah, okay. Both got that one. Yeah. Bonnie and I were just talking about her her poster that she's going to be doing, which will be about telehealth on COPD. So, what else? Wearable tech. Yeah, that was another one. Yes. And Bonnie, you weren't there yesterday, but in the session yesterday we had one group that was trying to develop, had the idea of some sort of wearable patch that would send off signals about blood pressure, blood sugars, and various other sort of vital signs to a mobile phone, and so to a carer, so that they would know how well that person's doing. So that's, I mean, which is like the extension of the telehealth idea. We've got 3. Anything else? That's a good idea. Yeah. There's been various European projects looking at this sort of wearable technology, and as you know, probably it's coming into consumer health quite a lot from many amongst athletes who go around with various bands, service user involvement. Yeah, sort of. I mean, I think it's just the shift in power. Okay, I'll carry on. I mean, the things that I had down were these before. So the electronic records, decision support. Let me just move that. Mobile, just basically, I mean, to some degree, it's implied in by you saying wearable technology, but mobile, everything's going mobile. The service user involvement, yes, really patient-led ideas and social media. I mean, the use of patient feedback sites and so on is growing rapidly, and